Sangeeta, Asmita, please open up the session then.
Sir, room is open. You can start the session.
Okay. So, good evening, everyone, for this AOCN's monthly webinar. So, moving on from the fetal and neonatal neurology, today we will have two exciting talks on infantile and toddlers neurology. So, to moderate the session, we have Dr. Rekha Mittal with us. So, with her, Madam brings in decades of experience in caring for children with pediatric neurological disorders. So, over to you, ma'am. Once we are done with these two talks, we have two interesting cases, which will be of 10 minutes duration. And I think you, madam, will be moderating the whole session. Over to you, ma'am. You may please introduce the first speaker.
Good evening, everyone. We have two talks this evening, which are, I'm sure, of great interest to everyone and anyone who's in pediatric neurology, and with the two fantastic speakers we have with us today. Dr. Sangeeta Yoganathan will be speaking on precision therapeutics in neonatal neurometabolic disorders. So, Dr. Sangeeta is very well known and renowned in the field of pediatric neurology. She is professor and head of the department. She's professor of pediatric neurology in CMC Vellore, which she joined in 2013 after doing her DM in pediatric neurology from AIIMS, New Delhi. And she has just recently concluded her fellowship in neurometabolic disorders from Sick Kids Hospital in Canada. And I'm sure she'll have she'll really share some pearls of wisdom with us, and we are waiting eagerly to listen to her. The second talk was to be delivered by Dr. Vinian, but he had to go for some family emergency. So in his place, Dr. Sandeep Patil will be speaking on epilepsy surgery in infants and young children. Now, Dr. Sandeep Patil is also very well known in the field of pediatric neurology, but especially so in epilepsy surgery. He did his fellowship from Amrita Institute in Kochi, and then went on to do fellowship in epilepsy surgery from Australia. So, and he has done a huge number of cases in pediatric epilepsy surgery. So I'm sure he'll have a lot of interesting things to say. These two talks will be of 20 minutes each, followed by 10 minutes of discussion, 5 to 10 minutes of discussion. And I'll request the speakers to stick to their time. And this will be followed by two case presentations. And the first case will be presented by Dr. Jayashree and moderated by Dr. Lokesh. And the second case will be presented by Dr. Akanksha and moderated by Dr. Sandeep. So with that said, I'll request Dr. Sangeeta to start her presentation. Over to you, Dr. Sangeeta.
Thank you, ma'am, for the kind introduction. I'll share my screen. Is my screen visible, ma'am?
Yeah, we can see your screen.
Yeah. Good evening, everyone. I would like to thank the team AOCN for their kind invitation. I'll be covering on precision therapeutics and neonatal neurometabolic disorders. As we all know, this topic is too vast, so I will restrict to a few important case scenarios that we often encounter in our clinical practice. We all know inborn errors of metabolism are individually rare, but collectively they are numerous. And as per the data from 2025, more than 1,500 IEMs have been described. And the age at onset of these IEMs are highly variable, ranging from the fetal life to the adult life. High index of clinical suspicion is essential for making a diagnosis because in the newborn period, they often mimic like a sepsis or a HIE. And the clinical phenotypes may be overlapping and variable. The neonatal screening with TMS enables pre-symptomatic diagnosis in some of the inborn errors of metabolism, which can help in initiating the precision therapeutics. So the precision medicine begins with precision accuracy in the diagnosis. So it includes early diagnosis, use of targeted interventions, and also which will help in the improving the long-term neurodevelopmental outcome. So the IEMs can be classified into three groups. One is the group 1 disorders, which involves a small molecule metabolism. The group 2 disorders, which involves the energy metabolism, which could be cytoplasmic energy defects or mitochondrial energy defects or the membrane trafficking defects such as glutamate transporter defect. Group 3 disorders involve the complex molecules such as lysosomal storage disorder, peroxisomal disorders, as well as the congenital disorders of glycosylation. The group 1, group 2 disorders often manifest in the newborn period with encephalopathy or seizures. This is because of the accumulation of endogenous toxic metabolites or because of the lack of synthesis of necessary biochemical product. So what are the group 1 disorders that manifest during the newborn period, which includes the amino acid metabolism disorders and organic acidemias, such as urea cycle disorders, maple syrup urine disease, non-ketotic hypoglycemia, sulfite oxidase or molybdenum cofactor deficiency, and few of the organic acidemia such as propionic acidemia and methylmalonic acidemia. What are the group 2 disorders that can manifest during the neonatal period? It includes the primary lactic acidosis, particularly the PDH deficiency, and fatty acid oxidation defects, including the Carnot cycle defects and mitochondrial beta oxidation disorders, and electron transfer flavin dehydrogenase deficiency. So the group 3 disorders that can exhibit during the newborn period include Krabbe's disease, early onset variants, and neonatal adrenoleukodystrophy, Zellweger syndrome, and congenital disorders of glycosylation. So when to consider diagnosis of IEM in a neonate? When there is a history of consanguinity with a positive family history, with a history of SIDS in the family members earlier, and if there is a clear identification of trigger with episodic decompensation, and the symptom onset after feeding in neonates. In examination findings, if it reveals skin and hair changes, abnormal urine odor, if it identifies the presence of a dysmorphic state or malformations, presence of ocular findings, failure to thrive, hepatosplenomegaly, and multisystemic involvement should always make the clinician to think of an underlying IEM. The laboratory findings include recurrent or refractory hypoglycemia, presence of a metabolic acidosis refractory to conventional management, presence of elevated lactate, deranged liver enzymes, hyperammonemia, and urine ketosis. So the IEM in neonates can manifest with acute encephalopathy, seizures, or they can manifest with a dysmorphic state and malformations. They can also manifest with tone abnormalities and movement disorders. So it is always important to have an early diagnosis to make a good long-term neurodevelopmental outcome. So it starts with a newborn screening, because a healthy start leads to a healthier life. So in the Indian scenario, it is still a need of ours to include the newborn screening as a mandatory procedure in the neonatal care. So what are the principles of management, acute management in a neonate with suspected IEM? So first and foremost important step is to run the diagnostic testing faster, shut down the catabolism with the use of IV fluid, particularly dextrose and the intravenous lipids, administer supportive care to maintain the airway breathing and circulation, and to remove, make measures to remove all the toxic metabolites and exclude the sepsis, and if any sepsis or any other triggering factors is identified, treat the triggering factor. So we will look at a few case scenarios. A term neonate, fourth-born child of a non-consanguineous parents, presented with poor feeding and maple syrup odor on day 6 of life. The child also had metabolic acidosis on day 7 of life. There was a positive family history. Previous sibling also diagnosed to have maple syrup urine disease, who died at 9 years of age. This child was comatose at presentation and had a bulging anterior fontanelle. So the newborn screening reports were available by day 7 of life when the child was symptomatic, which showed elevated leucine, and the plasma amino acid analysis revealed elevated branch chain amino acids, including leucine, valine, and isoleucine, and blood ammonia level was normal. So this is the MRI finding. You can see there is diffusion restriction of the perirhinalic white matter, thalamine, and the globus pallidus, and also along the corticospinal tracts. And also the MRS, you can see at 0.9 ppm, you can see there is a huge peak, which is the branching amino acids or the branching keto acid peak. This is an imaging from another child who has shown the, with an MCU, who has shown the intramyelinic edema. That is the splitting of myelin, the areas which are myelinated at birth show pronounced findings. So the classic and intermediate variants of MCO can have manifestations in the neonatal period, and they often manifest with irritability, poor feeling, lethargy, and they can have intermittent apnea. They can have opistotonic posturing or bicycling movements. And also, the biochemical findings reveal elevated branching amino acids and elevated allo-isoleucine peak. So the defect here is the branch-chain ketoacid dehydrogenase. So how will you manage? Manage these children? So first and foremost is to restrict the dietary intake of leucine, provide a special formula diet, and maintain the adequate hydration and calories by supplementing IV 10% dextrose or intravenous lipids, correct the metabolic abnormalities, eliminate the toxic metabolites, and address the underlying cause for the crisis, particularly sepsis. If it is identified, it has to be treated. Consider cofactor supplementation, particularly thiamine, and all these patients at discharge should be provided with a sick day management plan, like when they become ill or when they have like an immunization. What are the measures that needs to be followed? The curative treatment would be the transplantation of allogenic liver tissue, so which would be like permanent cure for these children. So this is a data of organic acidemias in the neonatal period. So you can clearly see from 1987 to 2017, with improvement in the newborn screening and also with improvement in the management of inborn errors of metabolism, the mortality has dropped from 86% to 7.4%. So moving on to the next case scenario, a term neonate, second born to non-consanguineous parents. Baby was on formula feed till 6th day of life, followed by refusal of feeds and progressive lethargy. He was brought to the hospital with hypothermia. He was pale and encephalopathic. At presentation, his blood sugar was normal, but he had respiratory alkalosis, and his ammonia was elevated, and he had a normal anion gap. He had a progressive drop in sensorium with severe hypotonia and generalized seizures. The child was managed with the resuscitative measures, ABC maintenance, and also the IV fluid with 10% dextrose lipids, and also maintenance of high adequate calories. And also ammonia scavenging drugs were also initiated on this child. So you can see the other biochemical workup revealed elevated urine orotic acid, and the sequencing confirmed the diagnosis of citrullinemia type 1 due to ASS1 gene defect. So urea cycle disorder can result from defect in any of the 5 catalytic enzyme defects, or it can result from the defect in the cofactor producing enzyme, or it can result from defect in the 2 amino acid transporters. So these neonates often manifest often or normal at birth, and later they develop hyperammonemia and cerebral edema, because of which they develop progressive lethargy, poor feeding, and hypoventilation, hypothermia, seizures, and coma. MRI may mimic like an ischemic lesions or HIE, and the insular cortex are pronouncedly affected. So if you look at the newborn with suspected urea cycle disorders and look at the ammonia, if it is very much elevated, look at the anion gap. Anion gap will be usually normal, and the blood sugar concentrations will be usually normal. Then you need to look at the specific plasma amino acid profile to pattern fit like and identify the defect in the pathway. So what is the management protocol for urea cycle disorder? First, in the acute phase, we need to stop all the protein intake, provide intravenous fluid with dextrose and IV lipids, and provide ammonia scavenger medications, sodium benzoate, sodium phenyl butyrate. Be prepared for hemodialysis if the ammonia level is not settling down with ammonia scavenger medications. Avoid and treat the underlying precipitating factors. In the chronic management, precision dietary management should be initiated, and deficient urea cycle intermediate products needs to be replaced depending upon the diagnosis. For example, if arginine level is low, you need to supplement the arginine. And carglumic acid has been found to be beneficial in patients with the N-acetyl glutamate synthase deficiency. And again, liver transplantation would be like a permanent cure for patients with OTC deficiency, citrullinemia type 1, ASL deficiency, and specific cases of arginase deficiency. And depending upon the appropriate scenario, we should consider supplementing a few of the products such as lysine, carnitine, and creatine. Moving on to the next case scenario, a 3-month-old girl, firstborn to consanguineous parents, was admitted with history of seizures from 9th day of life. There were no prenatal or perinatal risk factors. She had seizures on day 9 of life, and she was hospitalized for 10 days. She was managed with levetiracetam and phenobarbital. And again, she had seizure recurrence from 2.5 months of age, multiple seizures per day. Examination revealed microcephaly and spastic quadriparesis. So this is the imaging of the child. You can see multicystic encephalomalacia, and also you can see there is a hyperintensity and volume loss involving the basal ganglia, thinning of corpus callosum, and also the diffusion restriction along the corticospinal tract. So this child biochemical workup revealed low homocysteine level, low uric acid level, and urine sulfide was in the upper limit of normal. EEG revealed multifocal epileptiform discharges, and genetic testing revealed molybdenum cofactor deficiency due to MOXS1 gene defect. So the defect here is the molybdenum cofactor deficiency type A due to the MOX1 gene defect. So as a result of which the sulfate accumulation happens, resulting in the clinical manifestations. So these children often manifest in the newborn period, which closely mimics the hypoxic ischemic encephalopathy clinically as well as radiologically. So the consensus guidelines has been published for the management of these children with sulfite oxidase and molybdenum cofactor deficiency. So the precision medicine for molybdenum cofactor deficiency type A is the enzyme replacement therapy, fosrenopterin. So this is administered as intravenous and it has to be administered lifelong as a daily infusion. And the other consensus guideline statements suggest avoiding valproic acid of seizures in these patients, and pyridoxine supplementation may be beneficial in few cases. Thiamine supplementation must be considered if there is an elevated lactate in sulfite oxidase or molybdenum cofactor deficiency, and low sulfur diet may be beneficial in an atypical and attenuated forms of these cases. Moving on to the next case scenario, a 4-day-old girl born to a consanguineous parent presented with poor feeding and lethargy. She had low birth weight and her Apgar scores were normal. There were no concerns in the prenatal period. Her cry was weak and she had poor sucking effect and she had frequent hiccups and respiratory failure. There was no positive family history. On presentation, she was encephalopathic and she was intubated and she had myoclonic jerks on examination. So this is the MRI. You can see there is a hypoplasia of corpus callosum and EEG was showing burst suppression pattern. CSF glycine was elevated and the CSF to plasma glycine ratio was also elevated. So this child had biochemically features suggest as well as clinically features suggesting of non-ketotic hyperglycemia. So if you look in the non-ketotic hyperglycemia, the clinical manifestations can vary. So the types are classified into severe and attenuated forms, and based on the age at onset, it could be neonatal forms or the infantile onset forms. So if you look at the clinical phenotype, the classical forms have pronounced seizures and tone abnormalities, while the milder forms, they have pronounced choreoathetoid movements or the movement disorders and behavioral disturbances. So the spectrum of imaging findings in these children include hypoplasia of corpus callosum, enlarged ventricle, delayed myelination, cortical atrophy, and cerebellar hypoplasia. So what is the management? These children have elevated glycine levels. So to reduce the glycine level, we can supplement sodium benzoate, which will combine with the glycine and form hippuric acid, and it will in turn help to reduce the glycine levels. And the other medications are dextromethorphan and ketamine, which are NMDA antagonists. And these drugs can help to reduce the seizures, normalization of EEG, and also can help with the improvement of tone. So in patients with refractory epilepsy or refractory seizures due to an NKH defect, so we can try administration of perampanel, which has been found to be beneficial in reducing the seizure burden. The agent that needs to be avoided are valproate and vigabatrin. And in a GLDC deficient mouse model, they have found cinnamic acid and sodium cinnamate to be beneficial in reducing plasma glycine levels significantly. So moving on to the next case scenario, this is a term 2.4 kg male who was born to non-consanguineous parents, presented on day 16 of life with seizures, multiple skin abscess, and septic arthritis of hip and knee. He had respiratory distress for which he was intubated and he was on mechanical ventilation. Clinical exome study revealed biotinase gene defect, and the enzyme deficiency was also identified on the biochemical testing. He was treated with biotin, and follow-up he had normal development and there were no recurrent infection. So here the defect is the biotinase enzyme, so which is essential as a cofactor for the 4 carboxylases, which are essential for the energy metabolism. And this biotinase helps to release the biotin from the diet as well as the endogenous sources, and also biotin acts as a cofactor for the hollow carboxylase synthetase, which is essential for producing the active forms. So the children with biotinase deficiency manifest in the newborn period with tone abnormalities, refractory seizures, skin problem, dermatitis, alopecia, and skin rash. The later onset forms can present with motor weakness, spastic paraparesis, mimic, and also the decreased visual acuity, which mimics like an NMOSD. So the management includes lifelong supplementation of biotin, 5 to 20 milligrams per day. and avoidance of raw eggs, and use of cochlear implants in those with identified sensorineural hearing loss. And newborn screening is absolutely mandatory, as I was emphasizing earlier, because these disorders can be diagnosed, and early initiation of biotin can prevent the onset of clinical symptoms. So one other vitamin which deficiency can lead on to clinical manifestation in the neonatal period is the pyridoxine-dependent epilepsy. So pyridoxine-dependent epilepsy can result from defect in the synthesis of pyridoxal phosphate, or defect in the import of pyridoxal phosphate into the cells, or defect in the hemostasis, abnormal homeostasis of PLP within the cells, or due to the accumulation of metabolites that inactivates the pyridoxal phosphate within the cells. So children with the classical pyridoxine-dependent epilepsy manifest in the newborn period or in utero with in utero seizures, perinatal depression, low Apgar scores. They can have tone abnormalities, see polymorphic seizures that are refractory to the conventional anti-seizure medications. They can have movement disorders and behavioral abnormalities. So the biochemical abnormalities include elevated urinary ASA and piperacolic acid in the urine and the plasma. So there are again consensus guidelines published for management of these children. So for the newborns, we can administer a dose of 100 milligram per day of pyridoxine. And for infants, it's 30 milligram per kg per day. And for older children and adults and adolescents, it's the same milligram per kg per day with a ceiling of 500 milligram per day. So we also need to emphasize that the dose of pyridoxine needs to be doubled during the intercurrent illness, and also triple therapy, which includes pyridoxine supplementation and restriction of the lysine in diet, along with the supplementation of arginine, would be beneficial in improving the seizures as well as the long-term neurodevelopmental outcome. So this is the protocol in a child with neonatal seizures that are refractory to conventional anti-seizure medications. We can consider pyridoxine. If not settling down, we can consider adding folinic acid. Again, if not refractory, we can switch over the pyridoxine to the pyridoxal phosphate. Moving on to the group 2 disorders, this includes two main disorders. That's those disorders which manifest with the primary lactic acidosis in the newborn period. And the second group is the fatty acid oxidation defect. Among the primary lactic acidosis group of disorders, pyruvate dehydrogenase complex deficiency is one of the common disorders. So these children can manifest either in the neonatal period with encephalopathy and lactic acidosis, or they can manifest in the infantile period with non-progressive encephalopathy and seizures, or they can have lay-like presentation, or in the older children and adults, they can present with the relapsing and remitting neuropathies and the ataxia. So the defect here is the pyruvate dehydrogenase complex, which links the glycolytic pathway with the Krebs cycle. So this enzyme is encoded by the 7 genes. So when there is a defect in any of these genes, you can have manifestations in the resulting in the pyruvate dehydrogenase complex deficiency, with manifestations starting right from the newborn period. So the spectrum of imaging findings include gyration abnormalities, ventriculomegaly, cerebral and cerebellar atrophy. In addition to that, they can have paraventricular pseudocyst, dysgenesis of corpus callosum, and some of the infantile ones can have basal ganglia brainstem signal changes. So the biochemical marker includes elevated plasma alanine and prolin, with also low pyruvate dehydrogenase complex enzyme activity in the culture fibroblasts. So the treatment includes initiation of ketogenic diet, which is the precision dietary therapy for this particular disorder, along with supplementation of thiamine. So moving on to the next case, a 2-day-old neonate presented with history of lethargy and cardiorespiratory arrest. There were no prenatal or perinatal risk factors, and the child was discharged on breastfeeding after birth.
Sorry to interrupt, Dr. Sangeeta. You have about a minute more.
Yeah, sure.
Yeah.
So there is no family history. The child at presentation was cyanosed, and he was resuscitated after CPR. The child had respiratory acidosis, and his blood glucose was low, and lactate was elevated, and there was elevation of liver enzymes along with elevation of CPK and LDH. So this child again had a genetic confirmation of VLCAD deficiency, and the biochemical markers in the TMS and GCMS was also suggestive of the same. So this VLCAD enzyme is important in the beta oxidation spiral, which is essential for the energy production. And the TMS always helps to identify the type of the beta oxidation defect. So the management protocol includes avoiding fasting, and administer 10% dextrose 1.5 times maintenance, avoid intravenous lipid infusion, and supplement carnitine only if the carnitine level is low. We tend to supplement carnitine for all of the organic acidureas, but in fatty acid oxidation disorders, we should remember that The long chain acyl carnitine esters are highly cardiotoxic. So unless we document a low carnitine levels, we shouldn't supplement carnitine. We can give MCT in case of long chain fatty acid oxidation disorders. And triheptanoid is an FDA approved drug, which is an odd chain, which produces odd chain carbon atoms, and it synthesizes ketones, as well as it acts as a anaplerotic agent by producing acetyl CoA that enters the Krebs cycle to produce the energy. So I'll skip this few slides because of lack of time. Another important metal metabolism disorder which can have manifestation in the newborn period is the Menkes disease. So again, we need to identify children with Menkes because they typically have a characteristic profile: hypertonia, seizures, failure to thrive with skin and hair changes, with the biochemical markers of low serum copper and the cellular plasmin. So copper histidine administration has been found to be beneficial, and this has been recently FDA approved in 2026. So moving on to the last slide, the disorders of glycosylation. So these group of disorders, they can have monosystemic or multisystemic involvement. It is again essential to understand the phenotype and diagnose these group of disorders early, because we have precision medicine for this. The supplementation of mannose, galactose, fucose, and uridine and specific genetic defects has been found to be beneficial. So this is the last slide on the recent advances. We have RNA-based therapeutic agents available in phase 1 and phase 2 trial for few of the organic acidemias and the glycogen storage disorders. So precision therapeutics begins with precision phenotyping. So advances in newborn screening and rapid genomic sequencing and metabolomics may help in early diagnosis. Genomics should complement and never replace the clinical assessment or the biochemical phenotyping. Successful precision medicine requires multidisciplinary collaboration. Precision nutrition remains a cornerstone of treatment, and targeted therapies such as substrate reduction therapy or enzyme replacement therapy, vitamins or cofactor supplementations are currently expanding very rapidly. And the challenges include like limited access to the advanced diagnostics, high treatment costs for few of the gene therapies or the ASO therapies, and difficulties with the interpretation of the novel variants of the VUS, and ethical considerations in the gene therapies. So I would like to acknowledge and thank my mentors, my colleagues and trainees, the children with inborn errors of metabolism and their families, for all I have learned all these years. Thank you.
Well, thank you very much, Dr. Sangeeta. You have very, very nicely brought out how being able to diagnose each of these individual disorders can help us to precisely manage each of them. So are there any questions in the chat box? So, Dr. Ranjit has asked, how do we select patients for mannose and D-galactose supplementation in CDG?
Yeah, it depends upon the underlying genetic defect. For mannose is beneficial in MPI CDG. So it helps to improve the coagulation defects and malabsorption and protein losing enteropathy. Galactose is beneficial in PGM1 defect, SLC35A2, and TMEM165. So it depends upon the underlying genetic defects. You need to make a call like which needs to be supplemented.
So you brought out a very, I don't see any other questions, so I have a quick one for you. A very practical one that you mentioned in MSUD that you have a sick day management. So, but most of these disorders would have some kind of a sick day management, because many of them, when they go for vaccination or they have some fever or something, they can get aggravated, isn't it?
Yeah,
so do you have a kind of a general blanket advice for, because we can't go into the individual things, but do you have any advice for sick day management in general for
Yes.
these
So
disorders?
sick day management should be a written plan should be given to for those kids from group 1 and group 2 disorders where like small molecule metabolites intoxication, as well as in the energy metabolism defects. So the general plan would be like when the child becomes unwell for maple syrup urine disease, the parent should be taught to monitor the urine ketones, even if they are lethargic or if their intake is less. Even they don't become overtly symptomatic, but the urine ketones needs to be monitored. If urine ketosis happens, like the child needs to be hospitalized and start on IV 10% dextrose even before like they progress to coma or like floridly sick. So for other disorders, like you need to teach the parents to recognize the clinical symptoms, like warning signs. And then like we need to teach them like to present like to bring the child early to the emergency room, like in case of any of these symptoms, like such as poor feeding or lethargy, or like child not tolerating oral feeds. So in those cases, like IV fluid, 10% dextrose, 1.5 times maintenance should be administered to maintain a glucose, a high glucose infusion rate. In case if the child is not maintaining euglycemia, you can still increase the dextrose infusion through a central line. Or additionally, you can add up intravenous lipids 1 to 2 gram per kg per day. So this has to be continued during the intercurrent illness, and also you need to involve the dietitian for formulating the diet during the sick day. So we have to cut down the protein catabolisms, and also you need to stop the protein intake for the first 24 to 36 hours, and later initiate the feeds fast as soon as possible, because if you keep the child nil per oral for a longer time, they can cause protein breakdown, and again they can worsen. So and the supplementation of cofactors and vitamins, already the child would have been on. Like, so we need to see for few of the disorders, the doses maybe need to double during the intercurrent illness, like for pyridoxine-dependent epilepsy or for the biotin time and responsive basal ganglia disease. So you might need to double the doses of vitamins or cofactors during the intercurrent illness. So it is like actually a multidisciplinary involvement between the neurologist, metabolic physician, as well as the nutritionist, metabolic dietitian, to make a proper plan.
So thank you, Dr. Sangeeta. There are some other questions in the chat box. I'll request you to answer them in the chat box itself. And because we need to stick to the time, so I'll request Dr. Sandeep to start with his presentation. So he's speaking on epilepsy surgery in young children.
Thank you, Rekha ma'am, for the kind introduction. And i- are my slides visible?
Yeah, we can see your slides. Please put them in
Okay.
presentation. Okay,
Yeah.
thank you.
Okay. So today its topic is epilepsy surgery in young infants and children. And again, this is very uh, upcoming topic for surgical discussion, because many times we get a question like how younger child we can operate upon. And there are multiple new studies have come up where they have done early surgery, less than 3 months also the surgery has been done. So we'll go into details of this topic, epilepsy surgery in young infants and children. So the outline will be, we'll discuss about developing brain and epilepsy, how it interacts with each other. Then why the pre-surgical evaluation is tricky in these patients, because that's why um, the early surgery has not been performed regularly. But I think we need to do it as much as possible, because the earlier the surgery is done is better for the child. Then we look into the surgical complexity, because not every center will be able to do this, because there are a lot of uh, complication around the perioperative periods. We'll look at the outcomes, and we'll see few cases. So coming to the developing brain, so the epilepsy in the developing brain is different than the mature brain, like in older children. So when I'm saying young child is less than 5 years, and what I'm going to present is infants and toddlers. So is I'm just talking about up to 3 years of age. Uh, the immature brain is more seizure prone, because the immature brain is more excitatory in nature, so it is more prone to seizures, because this excitatory and inhibitory balance is actually tilted toward excitation in the immature brain. We all know that GABA behaves differently. GABA receptors are more excitatory in infants. The drug responses are different, and they are age dependent. And obviously, when you use multiple drugs, suppose we say drug resistant epilepsies, when you use more than two drugs, then we call it a drug resistant epilepsy. So if you use polytherapy, obviously that polytherapy is going to uh, harm the brain in like there will be developmental stagnation because of the medications as well. So why did seizures harm the developing brain? Because we all know that there's infancy is a critical period where there is a synaptogenesis. There are new networks being laid off, and when there are recurrent seizures, these networks get disturbed, or there is an imbalance between them, and there is a synaptic modifications, and the disrupt in pruning is also there. So then you get these seizures which goes on. Encephalopathy, apart from structural region, epileptic encephalopathy means there is underlying increased epileptic activity, which harms the development again. So it's not only the lesion, but the epileptic activity produced by the lesion also harms the development. And these are like a reversible things. Suppose if you have the lesion, you take out the lesion, then the encephalopathy reverses, and there's harmful effect of ongoing seizures and medications also we can reverse. And there is a neuroplasticity. So the neuroplasticity can occur better in young brain. So if you look at the burden of epilepsy, which begins in epilepsy infancy, so up to 50% who has or epilepsy onset in infancy gets developmental delay, global developmental delay. 90% of developmental epileptic encephalopathy patient have intellectual disabilities. Um, they are more likely to, around 3.7% are more likely to have severe or profound disability in DEE versus epilepsy with ID alone. And as we all know that the infancy is there is a highest incidence of epilepsy. So we all get the channelopathy, structural epilepsy, all they come in a infancy period. And if you include the toddler group also, so the incidence becomes more because you have West syndrome, LGS, which comes pretty early. So it's not about only seizures. The burden is about motor development, cognition, and behavior. So these are the three major domains which gets affected because of ongoing seizures, ongoing epilepsy, and ongoing epileptic encephalopathy. So you have delayed milestones. Sometimes you can have motor deficit also, like hemiparesis or regression in motor skills. Um, Intellectual disability can be there. Then the behavioral issues like hyperactivity, autism spectrum disorder, like poor social engagement, regression in academic milestones also can be there. So the thing is the infant brain is or young child brain is very susceptible. So the developing brain doesn't wait. Means if you have epilepsy and it is drug resistant and it is ongoing, it will actually affect all the domains, the motor development, cognition, behavior. It won't wait till your next drug. Okay. So coming to the pre-surgical evaluation, why it is difficult? Because we say that it is two drugs defined resistance, but sometimes infants can have like they can have multiple seizures in a day. So before you know that there is a drug resistance, that the baby is already on 3 or 4 anti-seizure medications. Epileptic encephalopathy we just talk about, and the plasticity. Plasticity is time limited. So earlier you do the surgery, more the brain will like improved in a there will be reorganization of language and motor function, and this capacity goes down as the child becomes older. So if you do same surgery at 6 months of age and same surgery at 6 years, the outcome will be different. Though both the patient will get seizure freedom, but the cognitive behavioral outcome or when you do the surgery at 6 months will be far better than the one you do at 6 years. Coming to the evaluation, why infant seizure simulation is hard to localize? Because many times you see, I get a phone call from the colleagues and say that okay, it's not focal seizure, it's a subtle seizure. because the brain has not matured. There are no networks which are there, and mostly the networks which are there in a infant, they are brainstem driven. So limbic and brainstem circuits are more developed in an infant. So what you get is a subtle signs like eye deviation, lip smacking, apnea, subtle spasms. And when you go through the epilepsy literature, it doesn't talk about all these. Okay, they will talk about classical localizing and lateralizing signs. So you will have eye deviation to the one side or figure of four. So those things you won't get in a infant because there is a not enough synaptogenesis or network developed which is there. Okay, and then you have unreliable lateralizing values. So tonic eye version can point either way. Localization related epilepsy often produces generalized appearing signs. So you can have means the signs which shows uh, generalized tonic seizure, but it can come from the focal lesion. And there is a frequent EEG and clinical mismatch. Again, many times you get just a slowing, which is seen on a surface EEG, and because if the lesion is large or lesion is deep seated, then you don't get good rhythm outside. Uh, Coming to the imaging that's if you see this neonatal MRI is very difficult, in terms of interpreting and analyzing, because in a neonatal brain you get a poor gray-white contrast. After myelination, the lesions can appear better, or there is a window, the disappearing window. So FCD, if you do the images before 3 months or after 24 months, then the FCD or focal cortical dysplasias are better visible. Otherwise, they are just get missed. And then you often get, okay, 6 months neonate comes to you, and then, okay, normal MRI. So this could be genetic, or this is not a surgical case. This is not the case. You will have to get at least good T2 images. Okay, so the T2 images are like where you see that the dysplasia better. Also, you can get a PET scan done or ictal ESL done. Okay, so the T2 is key because flare is not useful. So always look at the T2 when you're looking at a neonatal MRI. Coming to the surgical part, in neonate, these surgeries are complex because one, because of the age. Second, uh, the brain volume is more than the body, and if there is a blood loss, the blood loss is huge when you compare to the because these are the tiny neonates, like their weight is around 4 kgs, 5 kgs. So blood loss comparatively is on a higher side. So almost every neonatal surgery requires blood transfusion. So there are a few surgically remedial etiologies which can be tackled in neonatal age group, like a focal cortical dysplasia. These focal cortical dysplasias are bigger in a neonate. Like you will have lobar focal cortical dysplasia or multilobar cortical dysplasias, which can be there. Sometimes you have hemispheric pathology like hemimegalencephaly, and then you have tuberous sclerosis, which can have multiple tubers. Okay, and then you can have the low growing tumors as well, sometimes seen in a early childhood age, like 1 year, 2 year. I already spoken about this, like why surgery in infancy is difficult because the blood volume is less in a neonate, and the blood loss can cause a lot of problem. There is a problem with medication, open fontanelle, and immature physiology. So the coagulation is a big problem. Sometimes you may require to transfuse plasma during intraoperative surgeries, intraoperative period, and then also sometimes you will have to do the stage surgeries because many infantile surgeries are hemispheric surgeries. So when you when you're doing the surgeries, and if you have problem with the coagulation, sometimes you have to stop in between and redo the surgery next day, because neonate cannot tolerate the blood transfusion that much, and then the baby can go into the DIC. And then you required a good anesthesia team to manage the blood loss during the surgeries, and like managing the overall the electrolyte disturbance, sodium, glucose, potassium, BP control. Everything has to be better during the intra-op period and also post-op period. You required intense neuro and hemodynamic monitoring, electrolyte fluid balance monitoring during the ICU stay. The hydrocephalus is a one complication which is seen in hemispheric surgeries. There's one study which mentions around 25% of hemispheric infant surgeries go which develop hydrocephalus, and overall 14% overall needs CSF diversion. So that those things you need to look at during the ICU stay or post-operatively. And then sometimes these neonates can stuck into the ICU with on a ventilator because of their physiology and complication related to surgeries. These complications are higher in a neonates compared to older children. Blood loss and volume loss, we already spoken about hydrocephalus. And the main thing is you required reoperation and deficits, because almost 10% neonatal surgery will require resurgery. So because the dysplasia is not uh, clearly visible, or it is a huge dysplasia, required stage surgeries. So you always go with the intention to control the encephalopathy or reduce the seizure burden. And you can always come back and do the second surgery again. And then again, you required a good team. The good team with the surgeons, with radiologists, anesthesia, and ICU team to handle neonatal epilepsy surgeries. That's infantile or neonatal epilepsy surgery, because that's not a easy thing to do in a routine epilepsy center. So coming to the outcomes, these are the outcomes which are published recently, where you see that this is 2024 study, and I will show our outcomes as well. But the outcomes are ranging between 66 to 70%. So that is a very good outcome for major surgeries. These are not like bottom of sulcal dysplasia surgery. Here you are doing hemispherectomy, multilobar resection, or disconnection. So these outcomes are really good. And outcomes compared to development and cognitive trajectory, you see that almost there is a 50% of these kids will show remarkable improvement. Obviously, there could be a deficit because you are doing hemispheric surgery or multilobar resection, and it takes time to improve, but they don't worsen. So that is the most important thing. Either they will improve or they won't worsen. In cases of DE and ongoing epilepsy, they are definitely going to worsen if we don't operate on them. So let's see a few patients. This is 6-month-old presented with history of recurrent seizures since 2 months of age. On polytherapy, oscarbazepine, phenobarbital, levetiracetam, lacosamide, topiramate. And you can see there's seizure which is quite elementary. Let's see. It starts with a staring kind of episode, yawning. It's look how subtle. There are no localizing signs, just stare. And now maybe persistent eye deviation to the right side. Heavy breathing. This is like a very subtle seizure, hard to localize or lateralize. The only thing which can lateralizing is eye deviation to the right side here. So probably I'll put it on a left hemisphere, but it can be either frontal or posterior cortex. Seizure frequency was daily 8 to 10 seizures. And then when you look at the EEG, it shows left posterior cortex, epileptiform activity around T3, T5, O1, and you get beautiful seizure rhythm there, which is there from left side, left parietal temporal cortex, T3, T5, and it evolves. And when I looked at the MRI, what does it show? This is 6 months old, so you are not going to see the clear MRI. On contrary, it shows hypermyelination. So you can see this cortex on the left side compared to the right. You see there is a myelination which has happened, and almost posterior temporal lobe, this temporal cortex, temporo-occipital junction, and then occipital cortex. So this myelination is complete. So the one more sign in a infant is a hypermyelination. So if you see the hypermyelination on the MRI, there is a susceptible dysplasia there. Okay. So for this patient, we had to get the MRI PET scan done, and look at this PET scan. This showing quite hypometabolism on the left side compared to the right. And this was the plan because it was huge dysplasia. We went ahead with a PO resection, disconnection. We included some part of temporal TPO disconnection. So we included temporal as well as parietal and occipital. So this is the intraoperative picture. And this baby was seizure free for, this is a post-operative at 8 months. So the development has improved standing with support and babbling. So the development is preserved because of this surgery, because ongoing seizures, we could stop the seizures, stop the encephalopathy, and the development is better. This is another case. This is 2-year-old boy with history of epileptic spasms since 6 months of age, mild developmental delay with daily seizures on multiple anti-epileptic drugs, and genetic was done, and it showed VUS MFN1 gene, autosomal recessive in heterozygous state. So again, we get this notion that okay, if there is a epilepsy, means there could be a genetic and sometimes you get VUS, and we stuck there because we can't confirm it. But all drug-resistant epilepsy patient, even if they are uh, having genetic mutation, which is confirmed or not confirmed, should undergo pre-surgical evaluation, because there you will get some more information. Okay. So look at this boy now. The development is preserved in this baby, and then you get these spasms slash tonic drop attacks. Okay. So when I looked at this, the onset is diffuse. Okay. Now you see that there is a diffuse onset. So look at this. So diffuse fast activity, but it was bit prominent on right side, but and okay, and then when he's falling, he had a left hand kind of posture. So I thought it was asymmetric tonic or asymmetric spasms, but EEG, when you see, look at this. This is like for this EEG, you won't recommend epilepsy surgery, right? It is showing bilateral multifocal discharges, almost encephalopathic in nature. So when I went back and saw his MRI, this was at I think 8 months of age, and you see this streak which is going on, the white, the hyperintensity uh, around the right frontal lobe. And when he came to us, we repeated the MRI and we saw the similar streak on a right frontal lobe. Okay, so this was the catch here, because we thought maybe there is some asymmetry and the left hand is posture, and you got this abnormality which was there at 8 months and again at the 2 years. So we looked at the literature. It showed like age-related MR characteristic in Moge. So in Moge, you get this hyper intense streak around the cortex. You can see here. Okay. So we went ahead and did this right frontal dissection, and it turned out to be Moge. So you got oligodendral hyperplasia on this slide. So this is radiological Moge. Features are suggestive of mild malformation cortical development with oligodendral hyperplasia. This slide. Okay. Coming to the
Sorry to interrupt, Dr. Sandeep. You have
yeah.
just about a minute more because we need to take, there are lots of
Yeah.
questions in the chat box.
Okay, okay. Quickly, madam. So this is a 4-year-old boy, normal birth and development. Seizure onset at 16 months, slow fall on the right side, laughter, paucity of right hand movements, bipedaling, lasting for 1 minute. Again, this semiology is classical frontal lobe semiology. The laughter can come from mesial frontal, bipedaling movements, again, frontal in nature. But he responded initially with carbamazepine, but then restarted having seizures requiring multiple drugs. So this is the seizure. So he had a fall and he's laughing. Look at his face. He's laughing, turning in the brake, rocking. So we were sure that it is a frontal lobe semiology. When we looked at the ictal EEG, it was diffuse onset again, had some fast activity over left frontal, but his MRI was normal. Again, there is a notion that, okay, normal MRI, no epilepsy surgery, but we can still do the epilepsy surgery. This patient, we went ahead with a invasive EEG because MRI was negative, but semiology lateralized to the left. Video EEG, we thought maybe left more than right. And PET scan, we thought there is a left mesial frontal hypometabolism. We put the stereo EEG electrodes on a bilateral frontal implantation we did, and we explored the cingulate because we thought the laughing thing has come from the cingulate. And what we did, we capture the events and we capture how the seizure spread. So it started in the left mid cingulate, like here, the very low voltage fast activity, which is coming here, and then spreading to the right cingulate, and then it spread to the left posterior cingulate. So the onset we capture exactly in a mid cingulate. So we did the legionectomy and the child becomes seizure free. Okay. So this is our experience. We did almost 1,000 surgeries in last 10 years. And out of that, 30 infantile surgeries. If I add toddler, they will go up to 60 to 70 surgeries in early childhood. We did the stereo EEGs as well. Um, so the takeaway is um, seizure persists despite two adequately tried anti-seizure medication. You should think of epilepsy surgery. If you have focal or hemispheric lesion, you should think of epilepsy surgery as early as possible. We need to preserve the brain's baby's development, cognition, and behavior. So even with the spasms not responding to the medication, you should think of epilepsy surgery. Though even genetic showing some VUS kind of mutations, still you think of epilepsy surgeries. And obviously, when the lesion is quite visible there, then definitely you can go ahead and think of epilepsy surgery because time is brain and selection is everything. So we need to select the patient rightfully because there has to be concordant MRI, video EEG, functional imaging, and the surgical strategy should fit into the pathology. Otherwise, the seizures will continue, the encephalopathy will continue. So it has to be done. And obviously, as I said, the infantile epilepsy surgery will require a team which is competent from anesthesia, ICU, and everyone. The outcomes are good. Outcome justifies the risk. 66 to 76% seizure freedom is very, very good. And I think we should think of early surgery in infantile epilepsy as well. With this, I will stop and I will invite all of you for the conference which we are hosting in Pune from 11 to 13 September. This is in association with ILE Asia Oceania Pediatric Epilepsy Task Force, and it is going to be pediatric epilepsy surgery conference where we are going to discuss from semiology to stereology everything. So I invite you all to this conference. Thank you.
Thank you, Dr. Sandeep. That was really an excellent presentation, and it was very interesting. And you've taken some of the fear out from all of us regarding neonatal surgeries, at least today, because there is some sort of hesitation to really send newborns and neonates for surgeries. So there are although we've overshot the time, a couple of questions I think we can take, and I'll request you to answer the rest of the questions in the chat box itself. Dr. Bijoy Patra wants to know, how useful is epileptic surgery in symptomatic drug-resistant seizures in diffuse cortical lesions after there is an infection which has triggered some sort of lesion, CNS vasculopathy? So, I mean, in acquired conditions also, would you go ahead and do an epileptic surgery?
Yeah.
And how soon would you do it? That is his question, I think.
So the acquired lesion, maybe it could be vascular or vascular infarct kind of thing, or porencephaly because of the infarct, or gliosis. So we routinely do these surgeries. The obviously dictum is when the child become drug resistant. So whenever the child you use two appropriate drugs and the child become drug resistant, it has to be evaluated. Sometimes the lesion or the insult is localized to the one lobe, so we can do the lobectomy in those patients. If it is extending to the two lobes, then disconnective surgeries are better. But depending on the type of insult, we can think about surgery, but definitely we should think of surgery in even those patients as with acquired.
How much time would you give? Like, how much time would you like to wait for the child to recover from the acute insult? Would you do, say, 1 month,
No,
2
but
months, 3 months?
if acute
Or right,
insult
and then
patient,
yeah.
yeah. Yes, if there is ongoing surgery, ongoing epilepsy, sorry, after the acute insult, then probably, obviously, you can wait for 1 or 2 months. But depending on the what is the lesion, if the lesion is probably there is a structural lesion beforehand, the acute insult, then probably we can think of doing epilepsy surgery there. But one may wait for 2 or 3 months before establishing the epileptogenic process, because if the epileptogenic process is not clear, whether it's acute symptomatic seizure or it's the insult has completed and then there is a residual deficits there, so then you can think of surgery. So I will wait for 2 or 3 months there.
So Dr. Varsha wants to know if you have any experience and challenges with staged transarterial embolization hemimegalencephaly with early
No,
onset
no.
seizures.
No. So we haven't done it. So my colleagues in Australia have done it. So, but it's a kind of a multi-stage procedure where probably it's a bit high tech and expensive for Indian patients. So it is better we do open surgeries.
Surgeries, yeah.
Yeah.
So I think, thank you very much, Dr. Sandeep. There are
Yeah.
many other questions in the chat box. Hopefully you will answer them there. And
Yeah.
with that, we can, I think, move on to the case presentations. So the first case is from, let's see, by Dr. Jayashri. And instead of Dr. Lokesh, I think somebody else is moderating, I think.
Dr. Anas and Dr. Satish is
Okay,
going
Dr.
to
Anas is going to moderate this case or sort of be the mentor for this case. And Dr. Prashant, you will be moderating the case presentations. Am I correct? Okay, so I'll request the first presenter, that is Dr. Jayashri, to start her case. She is from Yashoda Hospital, High Tech City in Hyderabad. Dr. Jayashree, are you there? Is she there? You can start sharing your screen. Dr. Anas, are you there?
Yes, ma'am, I'm there.
Yeah. Dr. Jayashree, please share your screen. We still can't see your screen. Who's the host here? Doc-
Asmita here.
Asmita, can you please help Dr. Jayashree with her screen sharing? I don't see her or her screen.
Sir, in place of Jayashree, Dr. Anas will present.
Dr. Anas is presenting the case.
Dr. Anas and Dr. Satish.
No, I think Jayashree is presenting. We'll mentoring her.
No, but I don't see her screen. Dr. Jayashree, are you there?
Madam, can
I don't-
Akansha present? Then if Akansha is there, she can present the
Okay,
case.
I think then maybe the Hyderabad team can present later. Is Dr. Akanksha there?
Yes, ma'am, I'm there.
So I think maybe you can start your presentation first, since the other presenter is, I think, not online. So I'll request Dr. Akanksha Bhosle. She's from Dinanath Mangeshkar Hospital in Pune, and she's been mentored by Dr. Sandeep Patil. So you may start your presentation. Please share your screen.
Good evening, everyone. Ma'am, is my screen visible to everyone?
Yes, we can see your screen.
Okay. So today, good evening, everyone. So thank you for this opportunity. So I'm Dr. Akanksha Bhosle. Currently, I'm a fellow in the Department of Epilepsy at Dinanath Mangeshkar Hospital and Research Center, Pune. So today, I will be presenting a case of surgically
Please
treated.
can you put it in presenter mode?
Yes, ma'am. Surgically treated case of developmental and epileptic encephalopathy. So this is a 5-month-old boy child who presented with history of drug-resistant epilepsy for the last 4 months. The age of onset of seizures was at 2 months of age. So there was no aura. Ictus, he had left versive head and eye movement. There was behavior arrest. There was left facial motor involvement and occasionally associated with an ictal smile. Post ictal, there was quick recovery. The duration of the entire seizure episode was less than 1 minute. Occasionally, seizures progressed to bilateral tonic clonic at seizure offset. There was frequent clustering of the seizures, 4 to 5 seizures per hour, and the seizure burden was more than 5-6 seizures per day despite the polytherapy. Uh, the patient was treated with multiple anti-seizure medication, including oxcarbazepine, clobazam, phenobarbital, and topiramate. On examination, the CNS examination was normal. There was no focal neurological deficit, and there was no established handedness. The patient was born with the elective LSCS with appropriate birth weight. The neonatal period was insignificant and there was no perinatal concerns. Family history of childhood onset epilepsy in maternal aunt with well controlled on anti seizure medication. Development assessment was also a formal development assessment was also appropriate for his age. So, clinical summary, we have a 5-month-old male child with seizure onset at 2 months presenting with drug-resistant epilepsy with stereotyped focal motor seizures with left eye and head deviation, facial motor involvement, and evolution to bilateral tonic-clonic seizures. Seizures occurring in clusters with frequency of 5 to 6 episodes per day despite multiple ASMs, and developmental assessment was appropriate for its age. So at this uh, neu- neurological examination was also not significant. So at this stage, we suspected a focal cortical dysplasia due to the early onset of focal seizures at 2 months of age, with a rapid evolution to drug-resistant epilepsy, despite multiple anti-seizure medication and a stereotyped focal semiology. So I will be ictal EEG. Uh, is the screen visible? Hello.
Yes, yes, yes. Your screen is visible.
Okay. So I will
Please
be
put it in presenter mode.
uh,
We can
Hello?
see your slide heading says EEG ictal.
yes, ma'am. Just I have to share the screen.
Just option and picture.
Your screen is not
Uh,
visible.
Is the screen visible now?
Yeah, it is.
Okay. So here I'll be showing the semiology along with the ictal EEG. So we can see this 5-month-old child in awake state with normal activity.
We are you showing a video of the child?
Yes, ma'am.
But we
Video
can't
is
see any video. Yeah, we can only see the EEG. Typically,
ah,
when we present these video EEGs, until and unless it's a screen recording, usually they don't show up for some reason.
ah.
Yes, ma'am. So this
Akansha, can you just show the EG from where it starts? So basically, because of the just for the time, you can just show the ictal EEG.
okay. So I will show the ictal EEG. So this is we can see that the onset of the seizure begin uh, later, and we initially ictally had the slowing which was there over the left parietal, that is we can see the slowing which is there along with the temporal. So P3 T5 we can see the slowing has already begun. Post that there was this clinical onset of seizures where there was behavior arrest, there was this ictal smile followed by tonic posturing, bilateral tonic posturing. The patient continued to be in the tonic posture. So when the patient was in the tonic posture, so we see that there is again slowing predominantly over the parietal and predominantly over the temporal, that is P3 and T5. With further better evolution, we can see on the left side. And then there was quick recovery. So this was the ictal EEG of the patient. We will go ahead with the interictal. So this was the interictal EEG. So as we can see over the same area, we can see some slowing, which is there on the left parietal, that is P3, and similar on the T5 uh, leads as well. So there is slowing as compared to the right side. Then we can see IDs, good IDs over the left P3 and over the left parieto-temporal as well. So this was the EEG of the patient. So from the EEG also, we could localize the lesion to being on the left side and predominantly over the posterior head region. So this was the MRI of the patient. So as we can see, we have I have tried to put a good image so that the lesion we can identify here. So we can see that there is a lesion here on the left side temporal and parietal region. There is some thickening and some thickening which we can see. So this is the T2 image. Again, this is a
The hypermyelination part,
yes,
which we discuss on the
yes.
talk.
There is the
Yeah.
arrow which I have put here. So this is again in the coronal section. we can see that this is the same hypermyelination which we can see. This is the flare image. This is not very clear, but if we can differentiate, but like sir has mentioned, so T2 images are always better for localization. So this is the PET of the same baby. So we can see that there is hypometabolism in the same area, temporoparietal area. In the coronal section also we can see on the left side. So summary after the uh, investigation. So ictal on video EEG, we saw that there was an ictal, which was the onset of the seizures was from the left posterior head region, predominantly over the temporal and parietal contacts. Interictal, we saw that there was predominant left parietal and temporal IDs. So MRI, there was gyral thickening over the left temporoparietal area, and same area we had hypometabolism. So everything was concordant. So the patient went ahead with the ECOG guided resection of this dysplasia. The post-operative period was uneventful. There was no further seizures, no focal deficits, and was discharged on oral anti-seizure medications. So the brain biopsy was sent. So the brain biopsy was also suggestive of cortical dysplasia. So outcome. So the patient at 1 year of age belonged to the Engel class 1A. He was completely seizure free post surgery. He gained age appropriate milestones in all domains. And all the anti-seizure medications were tapered, and he was continued on a single anti-seizure medication with optimized dose. Thank you.
I think Dr. Prashant, you will have it. I have a question. Like just in your presentation, you talked about an aura in a 5-month-old. So can you explain what you meant by that?
Aura in a 5-month-old, ma'am, it is very difficult to.
So in this particular, so typically, one should be a little cautious before
It
talking
could
about
be.
an.
Yes, it could be excessive crying, could be a type of aura.
I think there was a mistake. There was no aura.
There was no aura, ma'am. There was.
I think in your presentation you said that it was preceded by an aura. So
No aura, ma'am. There was no
yeah.
aura.
Yeah. So that was just my point. But good, very nice, interesting case who has done very well. So are there any questions? If there are no questions, then we can move on to the second case. Has Dr. Jayashree been able to join? I don't see her. Dr. Prashant? Okay, there she is.
Ma'am, she's going to join in 1 minute. There's some issue with her laptop. So I'll be sharing the slides and she will be narrating the case.
Please, can you bring it onto the presentation mode?
If it is not possible, Satish, you can go ahead and present.
Okay, sir. I'll just
Yeah.
wait for 1 minute. In case if she's not able to join in the next 30 seconds, I'll start.
So till then, if there are any questions for Dr. Sandeep.
Good evening, Dr. Sandeep. I am Dr. Sasmita.
Good evening, madam. Yeah.
Many a time, I am sending ASL, and
Mhm.
we are getting the report that there is increased perfusion. So, in that condition, can we think of this cortical dysplasia without doing the PET scanning? See,
I mean,
MRI, it is very difficult in normal routine MRI, it is very difficult to differentiate whether there is any dysplasia is there or not for us, right?
but
So in
so the
ASL, hmm,
Mhm. So the ASL can show you the area of interest because it's a perfusion study. So in
yeah.
perfusion study, it will always show a bigger area. So it can show you the whole temporal lobe, which is abnormal, which you can go back to the imaging and have a look at every gyrus and see if there is any cortical dysplasia there. It is a very
Okay.
subtle sign.
Yeah.
Though people started thinking that ASL will replace PET, but it is not the case because PET will give you the accurate gyrus by gyrus hypometabolism, which ASL won't be able to do it. So ASL, if you're doing it, it will just an indicator that where to look at. So whether it's a temporal lobe, frontal lobe, occipital lobe, but it's a huge area because it is a perfusion study. It's not that accurate.
So I mean, after that, I should advise for the PET scanning, right?
Yeah, I mean, PET scan is always needed. With ASL, only you can go back to your original imaging, MRI imaging, and look at the dysplasia over there. Means, in that uh, cortex or that lobe, you have to look at the abnormal area.
Thank you so
Jash,
much.
Jash has joined. Or else Satyesh will
And,
go ahead and complete.
and one more question.
As a,
How
I think if the is Dr. Jayashree ready, or anybody from their
Satyesh?
team would like to start the
I'm
presentation?
ready. I'm ready. Yeah.
Yeah, please go ahead and complete. Yeah.
Who's presenting now?
Dr.
I'm Dr.
Satyesh.
Okay, please go ahead.
So today we are going to present 11-year boy born to third-degree consanguineous marriage with chief complaints of motor delay noted from late infancy, worsening of the attained motor abilities noted from 2 years of age, worsening speech clarity, which was noticed around 2 years of age, and sleeping difficulties from the last 1 year, that is around 10 years of age. Motor milestones, as per the history, there was only a partial neck control, never attained complete neck control, sitting unsupported when made to sit by 12 months, walking independently by 14 months, climbing stairs with support at 2 years, and never attained running or jumping. There was a mild lag in the fine motor domains, but speech and personal social milestones were fairly age appropriate. There was a history of worsening of motor abilities noticed from 2 years, which was an insidious onset and gradually progressing, with an inability to hold the head upright. There was a difficulty in getting up from the supine position. Child had to turn to one side and use his upper limbs to get up, or had to use his upper limbs to get up from a sitting position. There was a difficulty to squat. There was an inability to keep up with his peers while walking on inclined surfaces, with a difficulty in carrying heavy loads over the shoulders. But there was no major difficulty as per history while mixing food boluses, buttoning, or combing hair. There was no difficulty in wearing or holding on to footwear, not associated with any increased tendency for falls or any tightness or thinning of the limbs. There was no diurnal variation or fluctuation in the symptoms, and this was not associated with any cramps or pains. Coming to the speech clarity issues, this was onset was noted from 2 years of age. There was a difficulty in articulating sounds and especially a difficulty in pronunciation syllables like ta and kha. There was no difficulty in following commands and instructions. There was no history of any associated dysphagia like choking or nasal regurgitation. There was no difficulty in swallowing as well. Sleep disturbances were noted since the past 1 year, with mother noticing that the child was sleeping with an open mouth, with occasional snoring, which was increasing in frequency, not associated with shortness of breath. There was no difficulty in going to sleep or maintenance of the sleep. And there was improved overall because of these issues. They were evaluated elsewhere and started on night BiPAP, after which the sleep disturbances issues also fairly resolved. So, as I mentioned before, born out of a third-degree consanguineous marriage, during the antenatal period, mother had no decreased perception of fetal movements, but there was a history of oligohydramnios. It was a full-term vaginal delivery. Birth weight was 3.4 kg. Baby cried after birth without any significant perinatal history. So, as per the summary, we are dealing with a 11-year boy born to a third-degree consanguineous marriage with isolated delay in motor milestones and slowly progressive axial and proximal lower limb weakness with associated mild bulbar dysfunction and respiratory weakness with normal cognition. As per the history, the localization is mostly an element kind of a lesion with, since it is a diffuse involvement, I would like to keep muscle as the most likely first localization, followed by an anterior horn cell or a neuromuscular junction.
I'll take it from here, sir.
No.
Yeah. So the localization was muscle, myopathy, congenital dystrophy, metabolic myopathy, neuromuscular junction, limb girdle myasthenia, SMA3. So the points favoring for the myopathy are early onset, slowly progressive, early bulbar involvement, no contractures, normal cognition. Points against for the congenital dystrophy are no contractures, slower progressions. Metabolic myopathy, there is a slow progression and no stress-related worsening or no cramps. Limb girdle myasthenia, no fluctuation in the course, early onset and early neck weakness are the odd. SMA3, early onset for SMA3 and no tremors. So on, I will confirm the examination, confirm the history findings with the examination. The child is thin built, having the myopathic facies, has the hypernasal speech and nasal twang, has the articulation difficulty in ta and kha. So also he has bilateral facial weakness, hypernasality is there. But pharyngeal wall movement was preserved, no tongue fasciculations and shoulder shrugging was normal. So he has generalized hypotonia, trunk weakness, weakness from rolls to side, neck flexion and extensor weakness is there, 3/5. Modified Gore's time was 5 seconds. So reflexes were normal. Power, lower limb proximal muscle, lower limb proximal, 3/5. He has a waddling gait with the lumbar lordosis with inward turning of the leg. Summary. 11-year-old boy born to the third-degree consanguineous marriage with isolated motor delay, with slowly progressive axial and proximal lower limb weakness, with new findings with of facial weakness, myopathic facies, no hypertrophy, no mini myoclonus, preserved reflexes, and no fatigability that localizes to element type, and the group is muscle. So in the muscle, myopathy, the favoring points are no contractures and myopathic facies is the positive finding. Late onset Pompe disease, against point is slower progression. And congenital dystrophy, there are no contractures and no hypertrophy is noticed. Investigation, he was evaluated for the findings. So thyroid was normal, CPK was normal, spirometry suggestive of restricted lung disease pattern, muscle USG suggestive of calf and sternocleidomastoid fibrosis. The sleep study suggestive of severe AHI, sleep obstructive sleep apnea. So he was evaluated with genetic analysis suggestive of DPYD gene mutation with exon 14, which was pathogenic and autosomal recessive. So the DPYD gene phenotype, he fits in motor retardation, hypotonia, lethargy, onset in infancy, variable phenotype, biochemically uracil was positive, but no isolated motor or proximal myopathy variant noted in this. So we have done the reverse phenotyping. TMS was normal, GCMS suggestive of increased uracil, and MRI brain was normal. So this is the article. So our next plan was to do muscle MRI, muscle biopsy, or whole genome testing. Next slide. But the MRI findings for the myopathy were not that conclusive. So the next plan was to do whole genome sequencing and muscle biopsy. Thank you. So here we want the expert opinion regarding this case. Is this the phenotype? Is this the findings or the patient's features fits into the DPYD gene mutation?
Thank you, Dr. Jayashree. I think here the gene we found on lots of review, we are not able to find isolated motor myopathy variants. There are reports of psychomotor retardation. Almost all of them had some CNS involvement, either clinically or radiologically. Here, although there's biochemical evidence, we are wondering if this is, although it's a pathogenic variant with some biochemical answer, it may not be the sole answer for our condition. So I think question is open to the panel if they have seen any experience with such similar spectrum of disorders. Although wide variability is mentioned, but none of the case reports do mention such findings.
So a very relevant question by Dr. Bijay Patra is again, was an EMG done?
No, we have not done EMG.
So and also muscle biopsy?
Yeah, muscle biopsy is being planned based on, we are wondering before going for muscle biopsy, we should have a clear thing what we are looking for, probably because we may require special any special testing or electron microscopy. So we are next plan is for muscle biopsy versus whole genome. Whether what would be a better step before going
I
for an
feel at
invasion?
least because we can give more inputs to the genetics team if we do a muscle biopsy. Isn't it? What would be the opinion of the house? There are very learned people here. Dr. Sangeeta? So I do think, like you can do a whole genome sequencing, but still it would be important to give, to do a muscle biopsy first. That would be my opinion. So,
Okay.
yeah, because then the more information you give to the geneticist, the better it will be. Otherwise, you'll be doing more of reverse phenotyping.
Yes, ma'am. Since this was a recent reporting, I think we can go ahead with the muscle biopsy.
And we all know that genotype and phenotype, there can be, no matter how much it is, lots of variations are there. So maybe you just have a case where cognitively the child is okay. And it's just a muscle involvement. So there can be a variation. So I think it would be more important to do a muscle biopsy and see what shows up there. And if so, in the previous cases that have been reported, what has the muscle biopsy shown? Have they at least done a muscle biopsy?
No, ma'am. None of them have done, because none of them were purely exclusively LMN cases. They were predominantly psychomotor retardation as from the brain rather than pure LMN as such. No such reports of myopathy, even as a, yeah.
So this seems to be clearly a myopathy. So I think a muscle
Yeah, it'll be
biopsy
prudent
might
to go
be-
for biopsy. Sure.
Yeah, that's what I would. So I think two very interesting cases and two excellent talks have made this evening really very interesting. And I'm sure each one of the attendees has enjoyed this very academic input today. So I will request the organizers to take over from here. Dr.
Thank you, ma'am.
Prashant,
Thank you for
Dr. Naveen.
thank you, ma'am, for that moderating the session. And as you already mentioned, the two different aspects of the neonatal and infantile disorders, starting from epilepsy surgery and the metabolic disorders, and the challenges. Despite all the advances in the genetics and the metabolic testing, we can still have unanswered questions. So they were all exemplified in this presentation today. And thank you all the speakers, presenters for this presentations. Thank you very much. We'll see you in next month. Thank you.
Thanks to the AOCN for inviting me to moderate this session. It's been such a lovely, fruitful evening. I enjoyed all the four events. Thank you, everyone.
Thank you. Good night.
Thank you. Thank you, everyone. Thanks for invitation.
मोटर ना 20 मिनट ऊपर भर जाता है दोनों